be a little bit unorthodox in saying they were all members of the high priests of public health and the high priests of medicine at the time. So, well-intentioned, extremely skilled public health professionals, medical doctors, presumably, all from the public sector, because India had a very socialist tint to it, even though it has an active, entrepreneurial economy all through the last 7 decades. So very, very sort of state-centered approach, very narrow is the wrong word, lack of diversity in backgrounds of people debating it. So we decided two things at the get-go, that this would be the most inclusive commission that they could be. It would bring all sorts of people from across different schisms in Indian society who typically hate talking to each other. They don't hate each other, they hate talking to each other about issues related to health, because health is a very emotive issue. It's literally life and death, right? And so it's not something that people want to talk about. It's very strong. What are some of these schisms, do you think? Anyone? What do you think some of these groups of people would be who don't want to talk to each other? Some of you have developing country backgrounds. Maybe you can guess. It's not that different. No ideas?
Politicians don't want to talk to the public health experts.
Oh, for sure. Politicians don't want to talk to anybody. But that's fair, yeah.
Yeah. I was thinking patients and providers, or
yeah, nobody wants to talk to the patients because we are the high priests of medicine. We know what the patient needs, and the patient better listen to us.
Religion leaders?
Religious leaders, yeah, that is true. Minority communities, and recognize that when you say minority communities, we're talking about 400 million people. So it's a big population, would be underrepresented.
Rural communities and urban.
Yeah, so high priests are all from big cities for the most part, very well educated.
Capitalists and the high priests.
Capitalists. Yeah, absolutely. No private sector. No private sector allowed. If you're from the private sector and you run an organization that's related to healthcare and there's any whiff of making money or earning a living, you're persona non grata right away. You are ruled out. Now, here's the interesting statistic. Cole called you. What percentage of healthcare today in India is delivered by the private sector?
I'm guessing less than 1%.
Less than 1%. Anybody else?
I think 30 to 40%.
Answer is about 75 to 80%.
Whoa.
So think about that for a second. Most healthcare is delivered by the private sector. I'm using an expansive view of what constitutes private. Anything that's not funded by the state or is not part of, is not connected to the state apparatus, right? So that much is private sector, but private sector was believed to be purely profiteering and therefore ruled inadmissible in an area as sacred, if you will, as human health, and therefore excluded from the discussions. So not matching the facts on the ground, right? Yeah, sorry.
So my question is you're saying 75% by value or in terms of money or?
Anyway, you got it. You got it anyway. Basic point. And my numbers may be, there are various estimates, my numbers may be off. Okay, call it 50%, right? But it's, my bet is it's actually north of 75%, whichever way you do it. Sorry, you had a question at the back? Okay. So what we said was, we are going to do this differently, right, in the commission. We are going to make sure, first of all, the private sector is represented, right? That the citizen is represented, hence Lancet Citizens Commission. That's the first time any commission in Lancet's history has been called the Citizens Commission. We are basically signaling that we're going to walk the talk. This is going to be a different kind of report. It's still going to be subject to academic rigor. It's still going to go through the Lancet refereeing process. We're not compromising on it, but we are going to go and basically have an organized, large-scale process to go talk to the end citizen, who will typically be relatively uneducated, and in the median citizen will be uneducated, and well, maybe not the median citizen, but many of them will be living in inaccessible areas and so on, just to find out what is the nature of actual demand and what is the nature of actual supply. As an economist, I would say, can I actually characterize the demand curve and supply curve, which is fiendishly difficult to do, but conceptually, that's what we wanted to do. So we needed representation of people who could get to those communities, we needed representation of the private sector and the public sector and the high priest, so everybody has to be on the same table. And the last schism, I would say, that has become a real one in India, a result of something really good that's happened, is we've had a technology revolution in the country, right, over the last 20 or 30 years, with the software boom and all kinds of cool things happening. And I'm a participant in it, so I'm a beneficiary of it. So it's all terrific. But it's also sort of highlighted, the pros and the pros and cons of using technology to solve complicated problems, right? So you've got a bunch of people in the country who are predisposed to saying, let's use technology as a way to address some of these concerns. And you've got a bunch of people who are very skeptical of this, including the very vast majority of medical doctors and health providers who really don't think that their expertise should be interfered with, maybe the right, with all kinds of phones and gizmos and gadgets and sensors. They genuinely feel, my family's full of doctors and surgeons, so they genuinely feel that that it's compromising something in the doctor-patient relationship. So that's another huge schism. Right? So we want to make sure that technologists, technophiles and technophobes are both in the commission. Okay, so what do you think of this design construct? What's your reaction to it? What do you think of the design construct? Yeah.
I mean, I have a thought about maybe like the impression of this construct. You know, you're bringing the high priests of healthcare and the private sector to the table, underpinned by the Schumpeterian logic of creative destruction.
Yeah, it's like crazy.
Yeah, and I guess a couple of things come to mind. You know, I can imagine, you know, the public or the media distrusting the incentives and source of the money. I can also say that the way a Schumpeterian view of healthcare, that sort of puts the onus on individuals. Shouldn't it be the state? I don't know if there are.
Yeah, so remember I said at the beginning that the state has to be the steward and everybody. So we are very clear precisely for this reason, is that we're not saying that ultimately health is a public good. And so therefore the state has to kind of be the end all and be all. Supposedly, or de jure, the state is playing that role right now. De facto, that's complete nonsense. It's not, because everybody's going to the private sector, right? So it's not happening, but we still need to have the state at the center. What I meant more by Schumpeterian was that my way of thinking about it, it's not that everybody has to be a private entrepreneur, anything but how can we be creative about the process of getting to a better equilibrium than we are in right now? Lady in the back.
So you mentioned about Schumpeter, and that just reminded me of Kalesky's idea of political economy, where we talk about state versus the private sector, and we know that there are contradictions in the sense state don't want to take the role of private sector for a certain set of reasons.
Yeah, of course.
So how do we bridge that gap here? Because I understand the role of the state is important in developing countries, but given that bridge between the two sectors, between the public and the private sector, and the reasons why there are reasons why they want to, you know, operate in their own domains.
And they should.
They can't function without each other.
Yeah, so I didn't say, so be careful. I didn't say that they should do what's good, what the other should do. I just said that they should talk to each other.
Right.
Because clearly the idea that the state should completely ignore the private sector is silly, because that's where everybody's going. And unless you engage, you won't know how to. And there are plenty of abuses on the private sector side, as we see in this country. There's plenty of good apples and bad apples in both the public sector and the private sector. So there's no value judgment here. I'm just saying that there are all these different constituencies that should all be at the table. So two design decisions. One is this inclusive big tent approach, which hugely complicates the exercise in many ways. But we think that it raises the odds that you might find something that is acceptable to a broader coalition of people, and that might raise the odds of this not ending up in the archives without any effect. And we could be completely wrong. Time will tell. Yeah.
So is there significant differences in demographics between the groups that go to the public sector and the private sector for healthcare in India? So as in people who are unable to afford the private sector go into the public sector?
I'm sure there are in some populations and so on. I'm not competent to answer that, with proper data. But it's not even clear that the private sector necessarily provides unambiguously better care. It's just that in some sort of total cost of access sense, it must be, by revealed preference arguments in economics, it must be that it is ending up being more either accessible or amenable or friendly or cheaper or better, perceived to be better. Remember, healthcare is so complicated because when as my wife is a dentist, and when you go, she always says, how do the patients know that what we're doing is right? And the truth is you don't, because you can't see what's actually happening, right? So there's a level of trust in the whole system. So I'm sure it's true that that's the case. Either way, it's important to have Bree's perspective. Let me keep going, since there's a lot that I'd love to get through. So good news. It's not that health has not made progress. We made dramatic strides in India. In particular, speaking about vaccines, since we've just sort of emerged from this, or emerging from this pandemic hell, amazing vaccination rates in a poor country after the initial fiasco. Many of the world's drugs are produced by Indian pharma. Most of the vaccines in the world are produced by Indian pharma. So, there's this good side to it also, and I don't want to lose sight of it because that is an asset on the asset side of the nation's, healthcare balance sheet in some ways that we have to capitalize on. And then the disaster. 1 in 3 children in India are still malnourished today, right? Just enormous losses from unaddressed, non-communicable diseases, particularly diabetes. Just enormous losses. I mean, India and China, the diabetes capitals of the world, hands down. And there's just very little awareness of it, let alone any treatment. And the costs of that are just incalculable. Lots of bankruptcies. And look at the rank. We meaning India, ranks 145th out of 195 countries in health system. That's somebody else's ranking, but directionally correct. It's pretty pathetic. So this seems to me to be, as an academic, as a well-wisher of humanity, I suppose, this seems to be morally unacceptable. So I got involved in this project. So the commission, going back to the Big Tent approach, is led by 4 co-chairs, and the composition is deliberate. There are 2 of us there are 3 academics and 1 entrepreneur. 3 academics are myself, a professor at Harvard Medical School, who's one of the leading global mental health experts in the world, Vikram Patel, also runs a very, very big mental health movement in India through a nonprofit that he runs. There's a lady, Professor Kang, from a leading medical school in India, who's India's leading virologist, and has been all over the world just because of COVID. So she brings the solid science and the knowledge of infectious diseases and the credibility on the global stage. And a lady named Kiran Mazumdar, who's a friend of mine, who's India's leading self-made biotech entrepreneur. And she brings the connection to global science and to the emerging life science ecosystem in the country. So again, very unusual constellation of people. And me, who is the least connected to health in any formal professional sense, but hopefully bringing a different lens on this big social problem. So, sorry, I'm going to show you. There's an animation here that is just going to race ahead once I go here. So I'm going to ask you to bear with me because I'm not sure. It's basically 15 slides, each shift after about 2-3 seconds, but you'll get a sense. It's an animation of a small subgroup of the commission who are all the techies, right? Who are all tech entrepreneurs who are imagining a simple healthcare set of transactions triggered by a woman in village India, say 10 years after. Right? And then I'll use that vignette to try to illustrate some of the issues and the way that the commission is organized. So I think that might be an efficient way to communicate what's otherwise quite unwieldy. I should say that the scale of the commission has, I'm making these numbers up, but directionally, we have about 22 commissioners who are full-time participants. But full-time meaning that we all have day jobs, but we have responsibility for producing the commission report. that then goes to the Lancet for referee purposes. Each of those is connected to a set of institutions. So we've got another 30, 40 very large institutions across India participating in it, representing again, mainstream healthcare, mainstream pharma, medical devices, insurance companies, educational institutions, civil society, community health workers, village representatives, you name it, everybody's in. And we've got almost 200 to 250 researchers working on the report. So this is it's like a mini university that's trying to produce this. And the four of us are trying to steer it a little bit and try to produce. And what's coming out of it is just a blizzard of academic output. People are writing in their own fields. And the commission is set up as a tech-enabled platform so that people can plug in and play. And one of the nice things that's happened, because of the bad thing is that there is no existing large-scale public health platform in India for conversation, particularly where diverse people can come together. So the fact that this exists has rapidly made it a place to congregate, and that might, I hope, give it a life beyond the particular academic report that we produce. Okay, so here's the vignette from rural India in 2030. I'll let you see it. I'll keep quiet. These are community health workers. Sorry, it was too fast. One of my RAs did that and I couldn't figure out how to fix it. But what struck you? It's pretty simple. It's, a woman has a call in a rural setting, and basically triggers a call or something on a phone, and it sets in motion some stuff. What's your reaction to any of it? Look easy to do, hard to do?
It's simple. So
Simple.
it's
It's
actually
usable.
clear, yeah.
Yeah, it's very, very, very usable.
It's easy to use for tech-savvy users,
Sorry,
and it activates a range of different functions through a simple process.
it's connecting very different functions through a simple process. Okay.
It sort of seems like it takes the onus away from the patient in terms of seeking healthcare, because the phone was automatic, right? So,
But somebody she has to say that I have a call.
oh, she says that. I
Yeah.
missed that part.
Yeah. At some point you have to say that I have a problem. Yeah.
The aspect of accessibility in terms of the mobile screening unit coming as a result is also pretty interesting, because that would give access to the rural community.
Yeah. So if you have if people, obviously most people have phones now, an increasing number of smartphones, but there is a tech infrastructure that's enabling all this. It's actually quite a sophisticated tech infrastructure that I can talk about in a little bit. That's work in progress, but I'm very confident that it'll see the light of day. And it allows for sharing of docs, Gautam Ahuja is on the screen. So, by the way, guys, if somebody raises their hand or says something in a remote place, is there a way for me to tell them? Because I'm not going to be able to.
We can tell you.
We can tell you.
Okay, so one of you guys can say something. But Gautam was telling me that, the Cornell health insurance doesn't allow him to go to the Cornell hospital, New York. Right? So, and my students who are physicians and surgeons at, Beth Israel Hospital in Boston, they can't actually take their records across the street to the other Harvard hospital. Right? So it seems very easy to do, we can't do it in this country, actually. There is no prospect of us being able to do it in the foreseeable future in this country with all the debates. But the idea, one crazy idea that some of us have is that maybe we can avoid those mistakes and kind of build something that's closer to what looks like you.
There are three aspects that are relevant that I see that. One is the digital record. So you can actually share that and find out the fascinating that aspect. And how to train the community health workers, because that's the contact with the doctor, and that's the one who probably got the technology and will know how to use it. And how to recruit that people in the community. So that's pretty much what I find like. So
it's a very large, it's actually a very large scale operations problem at some level, right? Is maintaining this, I don't know, 1 million person workforce that's out and continually being trained and maintained and so on. I don't know.
So I just want to go back to the little slideshow that you have.
Yeah.
One thing that really struck me is how efficiently you are using technology. Everything from the mobile phone call to the health record system and what have you. So I just want to ask a very trivial question here. Is that, as you said, in the US, it's very difficult. Very difficult because part of it is this liability issue. My health record, I need to give consent. Where it goes, the patient does have some control over it. So one, how do you navigate that in a country where there's so much illiteracy?
Yes,
and
it's a huge issue.
It's the records used by all kinds of people.
Yes.
The other is, how do you train a vastly rural illiterate population on how to use the phone and how to transport themselves around?
Yes. So that's not a simple question. It's actually very complicated. Very complicated. The simplest questions often are actually quite complicated to unpack. Don't have the answers. But on the sort of techno-legal side, what we do have as part of these 200, 300 people working on the research for this is we have lawyers, including India's leading 3 or 4 property rights lawyers in some ways, who I've volunteered them to be part of the commission. And they're working with the technologists to come up with ways in which, for instance, the idea of just to amplify the underlying concern, which I think is legitimate, and I want to actually amplify it. The idea of informed consent when you are uneducated is a philosophically very tricky minefield, an issue. It's like, what does it mean when there is, I don't know if this is the right word, a power asymmetry between the person who has the knowledge and the ability to deliver care, and is a poorer person, and you're saying you should do this, right? But if with all our education, we might feel that way. If you are, God forbid, in an emergency situation and you go into a hospital and the doctor says, "This is it, sign on the form," right? And you say, "How do I know?" I said, "Well, you don't have a choice, because if you don't sign this, I can't touch the patient and the patient will be dead." So you sign, but you feel kind of helpless, right? Imagine if you felt helpless with every single thing because you just didn't know. So the idea of informed consent is not one that I think has a technical solution, but it has to have a solution, particularly in a vibrant, raucous democracy, where the citizen is involved in that conversation, which is why the Citizens Commission. So what we're doing is running a very large-scale survey to actually, for the first time after 75 years, go to the end citizen and say, "What is your expectation?" Right? And those surveys have been designed by trained social scientists who know how to do survey research and come up with sensible samples and things that allow us to make inferences. But that all will feed into what the lawyers and the technologists are trying to do. And then we have to put it out there as something that the world can comment on, and then put it through the peer review process, and then put it out there, and then figure out how am I going to now get government of India and Indian society to accept this. So it's many steps, but we feel like every mountain has to be scaled with steps. So we are putting in place, and at least this collection of people has the ability to congregate and the resources to congregate. So we got to try. That's the spirit of where we're at. But those concerns are 100% correct. And And any solution we come up with will not satisfy any extreme person. You know, the diehard privacy people will hate it. And people on the other side who want to do amazing algorithms with fine-grained data will hate it also. And that's how you know it's a reasonable solution.
Yeah, my concern is my friend, but I'm trying to say in a case because that mobile doctorate is good for people who are not in crisis, like.
Sure, yeah, this is like a primary care type setting almost, yeah.
It's like a primary care.
Sure, yeah.
So what about people with accidents or with a complication who cannot text?
Yeah.
Or who cannot use their brain? And what about data security? Because the mobile phones we'll be using contains everything, like banking, like all personal data. In a case you're not able to use your mobile and you ask, what about data security?
No, so first, obviously healthcare is enormously complex, right? I'm just using this to make an illustrative point to say that this is the kind of simple thing that even the simplest of things, if you unpack it, it has many technical, legal, philosophical, moral components to making decisions and trying to do. And of course, as you get to more and more complicated situations, life and death situations, which we face in this country also, right? What happens at the end of life, right? There's so many complicated moral decisions and economic decisions to be made. I'm not pretending that this covers everything. Of course, they're all there. But on the other issue, you know, this is one of the things that's really cool about what's happened. This is the positive side. The negative side of India is the fact that we are so bad at healthcare up to 75 years. I think it's a moral atrocity. The positive side is that we are so good at software. We're really good at software, actually. And what's happened is there has been sort of this, some of you, particularly those who are of Indian or South Asian background would have heard of the Biometric ID project that was started by a bunch of software colleagues in Bangalore primarily. It's called Aadhaar in Hindi, which is foundation, but it's a biometric ID that allows every resident, not citizen, every resident of India, right, to be uniquely identified with an iris scan or biometrics in a way that is not possible in this country, right? It's not possible in China. It's leapfrogged everybody in the world, essentially. And that has reduced corruption in many settings dramatically. It's also raised all kinds of philosophical and moral issues, endless litigation up to the Supreme Court in India, endless pushing and pulling and tugging about what the boundaries of use are of this biometric ID, as it should be in a contested political system, in a contested political democracy. But it has also triggered something called the UPI, the United Payment Interface, which is a whole financial architecture that you would find unbelievable. If you are concerned about data, right? So what do I have? My financial accounts are in a bank, right? Bank of America, a big bank in the US. My other assets are managed by Morgan Stanley and Goldman Sachs. None of the accounts can talk to each other. It's impossible to get anything shared. Everything has to go with me physically being there and the representatives to reach the financial institutions being there, let alone all these other investments that are in some other places, this and that. With the UPI in India, what the government has done is saying that we don't want to get to a situation where there are kind of monopoly providers that control the platforms, right? So look at the tech industry in this country, right? We're now actually very concerned about a handful of tech players, Microsoft, Google, Facebook, etc., controlling things, Amazon controlling things. And the pushback in US society is coming from the state, saying, wait a second, Congress is starting to say, no, wait a second, this is too much power, right? We have to curtail it. China, the same thing, you know, Alibaba and Tencent and others have too much power. So the party is clamping down and saying, stop it, can't do it. No, that's too much. Off with your power, you know, in a very, very sort of force majeure way. We are saying in India, we saw this movie. We don't want to go down this road. We don't want there to be dominant, entities that control it. Instead, we will create the digital equivalent of public highways. for finance, for identification, for healthcare, right? And everybody will be required to interface with this payment interface or health interface. Now the payment one exists and it's a huge success, huge success. In fact, you know, there was a very famous IPO that happened in India, a Paytm, which is a friend of mine, and it IPO'd at, I don't know, I mean, they thought they were going to get an IPO valuation of $15 billion or something, which is quite a bit of money anywhere, but especially in India. And UPI just made their life so much harder because suddenly what they were providing could be provided by many other people coming together using the public highway that the government had put in place, right? Which is all done by the same software engineers. And so UPI's market cap kind of fell from 15 to $4 billion, something like that, right? So it's a way of saying that the more public goods we have, right, then the more the prosperity is shared in different ways. There's still plenty of ways for entrepreneurs to be creative on top of the public good provision to do something interesting and novel. But the idea here is that that tech revolution has been one of the lovely things that has happened in India the last 20 years. And it still has legs to keep running. And those people are part of our commission, right? All the people who built those tech stacks and so on. So again, we've got everybody from traditional, practitioners of traditional medicine. Oh, by the way, that was another schism that I didn't talk about, right? We talked about the private and public sectors. We talked about rural, urban. We talked about technophiles and technophobes. The other huge schism in that is that, I mean, some of you are from China. I mean, every time I walk in a Chinese hospital, first thing I see, there are two things that I see. I see a bulletin board with all the prices. The second thing I see is this is traditional Chinese medicine and this is other medicine. You can choose which one you want to go to, right? So in India, we have a real schism, which is, the hospitals are all allopaths, essentially modern medicine training, the sort that, my wife trained at, my family members trained at in this country. But a very large proportion of healthcare is provided by these traditional healers, Ayurveda, and others. The acronym is Ayush. It's actually a ministry in the government called Ayush Ministry, which is essentially traditional methods of healing. Now, my doctor friends kind of generally dismiss it, saying that's not scientific. My view as a social scientist coming to this conversation is I don't care. I don't care whether it's scientific. I don't care whether it works or not. The point is that that's the only person who has the trust of the patient, right? So you better work with this trust repository and figure out, don't throw stones, help the process, right? Figure out what parts of their system works, figure out how you can graft onto it, figure out how you can enlist it, instead of, just exacerbating these divides, which has been going on for decades. It doesn't work anyway. Not a popular view, but I'm not in the business of popularity. So but that's another schism that we have. So we have represented in the commission, very sort of high-ranking people from that traditional medicine field. And we give them a voice. Again, you don't have to agree, you just have to be respectful of the commission at some point. Okay, so the commission is organized into these 5 work streams. In other words, there's a couple hundred people working on it, right? There's 20, 22, 24 commissioners, a bunch of people working primarily on basically gathering information from the end citizen, like the surveys and the methods and the case studies and the mini case studies, and large sample, this and that. There's a group of people working on the governance of the overall system, somebody working on human resources. You saw in the app, that was your comment, is that the human resource challenges here are just gargantuan. The number of people that have to be engaged in this, the protocols, how they relate to each other is very large. Financing is a big issue and tech is a big issue. So those are the buckets that we broke it down into. There's no science to this. It just seemed like these are important kinds of things that needed to be addressed. So the commissioners are kind of divided into whatever it is that they want to work on, but each kind of block has a couple of people in charge of it. So firstly, I work mostly on the financing and the tech side, so that's what I know more about than the other pieces, but we're all kind of aware of what's going on. So this process has been going on for about 18 months. It was slowed down by COVID because obviously the data collection from the citizens was very difficult to do. And probably will produce a report in calendar 22, the final thing next year. And then after that, we'll see what happens. But you can see, if you go back to that cartoon vignette that I showed you, right? One of the big things in financing, for instance, is there's no money changing hands there, right? In that vignette, there's nothing. Right now, insurance markets in India are very, very poorly, practically non-existent. There's more insurance now in India than there was 10 years ago, but it's still sort of extremely low penetration. And the out-of-pocket payment in India is extremely high, right? Again, the median is you're going to a private person and you're paying out of pocket. And that is extremely difficult to do if you're most socioeconomic segments in India. Even if you're in sort of the middle class or even the upper middle class, you get one bad draw from the health lottery and you're in real trouble. So that out of payment expense has to be addressed. In our imagination, we need to reduce that. In the limiting case, we need to eliminate it completely. That's not going to happen. But the more we can reduce it, the more affordable it becomes. Because the idea of universal healthcare is equal or equalish access to everybody, primarily more prevention than cure, and without triggering financial distress. That's an important boundary condition because if every health setback triggers financial disaster, well, it's not clear you're better off at the end of the day. Yeah.
About the financing sources of insurance providers now, I feel like there's an issue that comes up often, but not enough, is that the incentive for preventative care is often much weaker.
It's very weak.
If you're trying to shift a system towards that, are you feeling blowback or being resistant to doing that?
Look, I think everybody, including this country, everybody recognizes that we would all be better off if we had much more emphasis on prevention. I mean, at least in this country, we have regular checkups, right? You get a notice from your doctor saying, your annual checkup is due, or somebody reminds you, you go through at least basic tests. So the odds are higher that you catch things. But even here, if you think about it, those of us who don't eat healthy, right, are effectively basically avoiding prevention, right? And implicitly making the trade-off that we'll eat, more unhealthy because we enjoy it, and then we'll deal with the consequences later. And that happens. So it happens everywhere. It's a mindset shift, and I don't have any magic solutions to it. It's going to be, I don't think there's resistance to the idea of it. People are just kind of stuck in their own silos and their own ways of working. And so a big emphasis for us is, and a driver of the whole report is that a lot of what needs to happen is mindset change. We all kind of need to agree on, or come closer to agreeing on a feasible set of possible outcomes, right? And then work, I would say, opportunistically on triggering the mindset change that allows us to start moving in that direction. And one of the ways that I've organized some of the presentation, I almost certainly won't get through it, seeing as it's already 12:30. But one of the ways we've organized it for each of these, buckets of work, there are a set of mindset changes that we are sort of trying to document and saying that this is kind of the shift in thinking that needs to be done. Because if you're not thinking the right way, your actions are going to be all over the map, and the coordination is going to be just fiendishly difficult to pull off. Yeah.
To that point, and to your earlier points of building a trust repository, what activities is citizens engagement work stream focused on right now?
So let me go through some of these work streams, and then you'll have a little bit of a flavor of it. And so I already spoke about this. These are all the schisms, sort of speaking, right? So we've emerged as the public health the public health platform. So what happens is, because people know about this, anybody who's doing stuff on public health related stuff or healthcare related stuff comes to the Lancet Commission and says, can I use the platform for something? And we're very happy when people do that. So we host it. We have webinars. Our webinars are extremely well attended. We have at least one public one every month. People dial in from all over the world. again, all it speaks to is not that there's anything incredible that we've done, it's just that there isn't a pre-existing platform that was being made available. And this is starting to become one. We have sort of 10,000 people hitting the site every single day. Right? They're not necessarily unique users, but it's pretty decent scale already. So Citizens Commission, the citizen is at the center for us, which is a dramatic departure from any past public health report in, well, any developing country actually, because it's always the high priests who are deciding what should be done. And I wish it were, but it didn't. And this just says citizens are very broad tent. It includes the community health workers, it includes those, the cartoon images of the health workers who are going to the lady's house. It includes the lady herself, who's the demander of healthcare and the supplier of healthcare. Just trying to find out that in practical terms, what is it that you would like to see happen in your kind of professional or personal existence vis-a-vis health, and collecting all kinds of survey data on this. Obviously within the constraint that the respondent has to be willing and able to do the survey, so you can't have it overly complex, but that's a constraint for any survey exercise. So to Andrew's comment, I mean, mindset shifts, right? We just use this as a way to remind ourselves of really how difficult this is. Because to get you all have, we all do, I do, you do, preconceptions about whatever issue that you're thinking about. And it's very hard to change preconceptions, right? But the preconceptions here are stop thinking of citizens as passive actors in the healthcare system. Right? Think of them as actively engaged in this. Think of them as bearing responsibility also. Give them more power in their hands and more agency. Hold them accountable, which is very difficult. And to Arnab's question earlier, if you're not educated, it's that much harder. Right? And you've been socialized into being on the receiving end of everything, and suddenly you're being asked to be responsible for your own health. That takes a lot of guts, actually, for the person to sign on and say, okay, I'll sign on. I'll sign on to it. One of the enduring puzzles to me in engaging with this work 18 months ago is when you ask people, when people are voting, right? So this is a electoral democracy. People get voted in and out of office. It has its own flaws. It has many good features. But when you look at voters' concerns, health is nowhere. It's not there. It's just not there. It's life and it is just not there. Right? So think about that. What do you think about that?
It's kind of crazy, especially.
It's crazy. That's what I said.
I mean, we have inadequate health outcomes here too, but it's a huge public debate over.
Yeah, I mean, here governments rise and fall. Yes. On Obamacare, and Hillary care, and Romney care, and all sorts of stuff. And it's like the last Republican administration spent all this time trying to kill Obamacare. Right? It was that the issue.
Right, and so like. I guess it ties back into your mindset shift, and that voters really don't see this as their responsibility. Like, is it that they don't care about it, or is that they don't feel like they have any ability to affect the outcome?
Good. Well, we have to go to the citizens to find out. That's why we have a citizens engaged citizens survey, right? They may be socialized into thinking that this whole thing sucks anyway. What's the point? I'm trying to do something, right? It could be just helplessness. It could be learned helplessness.
So I just want to add something to this.
Yes.
So I've been working with a data set called LACI, longitudinal age study.
David Bloom's study. Yeah.
So I've been working with it a little bit, and it's a very unique data set that looks at health differences across some dimensions. They actually ask people about their perceptions, and their actual blood tests, drip tests, and so on and so forth. And the actual results. So what I'm looking at is the level of underreporting or overreporting based on gender, income classes, age, so on. Anyway, two observations in order. One is that it seems, at least at the first pass, that the poorer people, the bridge between what they actually think about their health and the actual numbers closer. So, and yet they don't access health. Same thing we're noticing, a little bit weaker women. They tend to know if they have hypertension or if they have depression, they're able to predict it much better than the middle class or the upper middle class or the relatively richer population. So the question about why healthcare is not an important issue, it doesn't come up in elections now. Because Indians have been conditioned to believe that health is a question of fate. So if you talk to any poor villagers, why have we been ill? Why have we not? Oh, it's just our fate. It's a conditioning thing that has happened over the years.
Learned helplessness,
And the other is the level of trust, right? Because doctors really mistreat poorer patients. The level of there's no empathy, there is no nicety, there is no. So the mistrust grows over time, and they don't want to really go and be abused. So I think
there's a very helpful observation. I should follow up with you on Lassie. Lassie was created by David Bloom, who's a mentor of mine, a public health economist at Harvard. It stands for Longitudinal Aging Survey of India. It's a wonderful database that's been created. But to me, I mean, as a kind of social scientist approaching this complicated health issue, I mean, when I saw that it doesn't show up at all, I said, this is crazy. How can it be? I mean, if my family is dying from lack of access to healthcare as the median poor person in India, why am I not holding my elected representatives? The only thing that shows up is jobs and hunger, food, jobs, and hunger. That's it. Those are the only two voting things for most people. If you can do that, fine. Health, when we get sick, we'll worry about it. Or we don't trust them, or nothing's going to change anyway. So this to me is like a huge lever of change. And by the way, the government of India refuses to spend money on health. The amount of allocation as a percentage of GDP to health is minuscule compared to even other poor countries. And part of what we do in the financing work stream, I'll get to that in a second, is to say not only is the aggregate commitment to funding health low, but whatever is being given to health is horribly misused, insanely badly misused. And so, how do we think about that? But really, the idea here is that, you can see, I'm not going to read every one of these, but the idea is that you've really got to change the way that citizens think about their role in the healthcare system in a fundamental way. And that's not like flicking a switch on and off. It's kind of getting around this decades-long learned helplessness that's kicked in. I'm just using that phrase because I think that's what describes it, but I don't know that in fact. Yeah,
I was just wondering, so I understand the citizens and voters have a role, but at the same time, I was just thinking that even the candidates who stand for the election, so what's on their agenda is equally important, what they are trying to sell in the market. So what I could feel in India right now, I am from India, so in Delhi, for example, Arvind Kejriwal has come up with these mohalla clinics.
Sure,
So that has become an important part of the debate and discussion now in Delhi and in the nearby states where probably AAP is planning to contest. But that's not the case that we see in, and I think even in southern states in India, health is comparatively an important issue as compared to the northern states. So I think the candidates also play an important role when it comes to the...
look, these are all endogenous outcomes, right? They're political systems, and you're absolutely right that there's a supply and demand of voting behavior in some ways, and both sides have to matter. I agree with that. I also agree that southern states in general are better educated and more farsighted, shall we say, than the northern ones, and you probably will see those kinds of patterns in the data. Let me, it's 12:40. I don't see anybody here. Okay, so finance work stream, I already said, why is public health expenditure in India so low? For the money being spent, why are the outcomes so pathetic? And when I say pathetic, I mean pathetic. I mean pathetic on some measures worse than sub-Saharan Africa, which is a lot poorer, and worse than other South Asian countries, which are in different states of their own disarray. So there is really no charitable way to say this. It's just bad. Mindset, everything has been in financing, everything has been about direct government intervention. And how do we, one person put it to me like this. She said, it's interesting when you go into these public health conversations with the government-owned entities, that it's all about optimizing the performance of the government-owned entity. Right? How do we make the public hospital work better? Which is fine, but that's not the point. The point is, how do you make the citizen healthier? That should be the center of it. And that's a different question than how do I make a government hospital healthy, right? So the government hospital might say, oh, if the private guy starts providing better care to them, what will happen to my hospital? What will happen to all my employees? What will happen to my vote base? And so I don't want to do that. So the conversation is not centered on the citizen. That's an example. What else would I highlight? One of the things that we see with outcome-based care that I think in this country has been sort of pioneered by Kaiser Permanente in California, basically saying, okay, we pay, the insurer pays the healthcare provider a flat sum per patient or per disease or something like that. And then, if the outcome is well managed, then the company stands to make some money. If they kind of mess it up, then they don't. And so there's an incentive for the healthcare provider to worry about outcomes, not just do more procedures. That is something that clearly should kick in worldwide. And it's a lot easier for a healthcare provider to say, I just want to be paid per procedure. So let me just keep doing procedures. And you see that in India. You see that in this country also. We see that in India where, for instance, cesarean section rates, even in the southern state of Kerala, C-section rates are off the charts. Because people are getting paid for it. So they're just doing it willy-nilly, right? And mortality is high, everything is bad. But so we need to move towards this sort of outcome-based managed care. This is the C-section example. It's true. The one at the bottom is kind of interesting. With a couple of people on the commission, I wrote this piece for Brookings, just like a longish op-ed. That essentially said, so there is a legally mandated pension scheme run for lower income employees of public sector entities. Right? So people working for government entities, government-owned entities, who are the lower income, they're required to contribute towards this insurance scheme. They've been required for decades, and they've been contributing. And that money is supposed to be used for a variety of things, especially, but certainly including health. That money is never spent. They just keep collecting it. It's built up into $10 billion the last time we checked. It's just sitting there. And there's a whole bureaucracy on top of it. And people write, op-eds about why is this money not being spent? Why is this money not being given back? Why are you collecting this money? And it's an automatic deduction, so nobody really has a choice. It just goes off the paycheck. It's an example. It's money that's actually burning a hole in somebody's pocket. And I don't know whether there's any misuse or not, but it's certainly not being used for what it's supposed to do. And when you look at the entire system, there's any number of these things. So one of the ideas that I was trying to advance that so far has had no traction is to say, let's not get stuck in the debates about we have to get the government to invest much more in health, because the government's response always is, well, I got to worry about food, and I got to worry about defense, and I got to worry about education. This is just another one of our priorities in a poor country. Let's at least use the money that we have better and start building the trust of the citizens and changing the mindset. No traction so far, but it's a long shot. Okay, technology. I already spoke about this. So basically, there is a supply side shock to technology in some ways. We have a lot of technologists who are capable of rethinking the tech architecture, but there is an important caution, which is medical doctors are, in my view, rightly skeptical of the what I would call Uberization of healthcare. Right? And so in the limiting case, imagine what this would be like. You have a tech-enabled system, right? And somebody says, I got a cough, and you go and you kind of click on something and a doctor shows up and they download your report, and then they prescribe something and they go away. And the next time you go back, you say, I want to get my thing checked. And a different taxi driver shows up, different doctor shows up, and you restart the whole process. Doesn't quite seem right. It seems a little bit impersonal and so on. So I worry about that. Medical professionals worry a lot about it. Whether this tech stuff is a runway train just happening because we know how to do something with it. And I think that's just something that needs to be adjudicated through trial and error in some ways. And that process is underway. This is the biometric ID logo, and this is unified payment interface that I think is state of the art. I think it's probably best in class in the world again, the financial architecture that enables all this. So what I want to say, so here's an example, right? This is an interesting debate that's going on right now. So very famous, one of the guys who was part of the Biometric ID project, who's a friend, I wouldn't say close friend, but a friend, the MIT guy, has teamed up with one of the most celebrated venture capitalists in America, the postal other guy with Sun Microsystems, and they've said, oh, during COVID, we were able to use technology to figure out sort of a marketplace of sorts for ventilators and masks and this, that, and the other in India, and it worked pretty well after disequilibrium in the beginning and chaos and so on that we all went through. And it led them to build an entire software architecture for this. So their thinking now is, why don't we do what's called the 10-bed ICU project, which just actually kicked off in the Northeast Indian states, which is side of India that's close to the Chinese border and the Bangladeshi-Burmese border, and is generally quite underdeveloped relative to the rest of India. So they said, why don't we kick off the 10-bed ICU project, which is a very tech-centric view of how we might work in places where health infrastructure is low. Literally just kicked off 2 days ago, whatever the politician went in. But this is what's in a 10-bed ICU. It's got all this basic equipment, mobile X-ray, a warmer, defibrillator, infusion pump, filters, resuscitation devices, blood analysis, basic stuff. It's not that expensive. You can now get it, you can source it, you can build bank at scale. So the idea is that we put all this, we have 10 beds in a 10-bed ICU, we stick all this equipment in there, right? And then we have this integrated command control center, right? Somewhere that's going to watch all the ICUs, right? And kind of share stuff and so on. So this is a vision. What do you guys think about this? You love it?
Love it.
What do you like about it?
It's repeatable, I guess.
Okay, so once you figure out a 10-bed ICU, you can replicate it.
If it works, then yeah, I'm interested in the costing as well, but yeah.
Yeah, okay. Anyone else?
What's a 10-bed?
We came up with some number. We need a minimum number of 10 beds. So you literally have 10 beds. So that's the capacity.
Literally have 10 beds?
Literally have 10 beds. And that's the capacity. They'll say in this rural center, right? Yeah, the one good thing that they're trying to do is to say, so I have to say the doctors are incredibly skeptical of this. The idea that you can, remember it's a 10-bed ICU. So if you go to any hospital, including Cornell, right? Emergency medicine is a different specialty. Right? Because emergency medicine is perhaps maybe one of the most complex things to pull off. Right? You come in, it's all time sensitive. Every case is life and death, things are blowing up and stuff like that. The concern is that I'm trying to articulate my medical friend's concern. I'm not sure I can do it perfectly. I know I can't do it perfectly, let me try. The concern is that the ICU is the wrong thing to do. That we should do other stuff and come up and protocolize things that are easier to protocolize. But the proposition that you can be sitting in Bangalore and protocolizing stuff as it's happening in real time in Manipur, some distant far northeastern state, let me be polite and say it's work in progress, if that. And it remains to be seen whether it works out. Okay.
This is a great idea, of course. One of the great resistance that you're going to face is that medical malpractice is huge in India. And the C-section is essentially, I don't know anybody who has not been born by a C-section.
Yeah.
So whenever you bring these technologies into play, physicians get extremely nervous because
they're very upset actually right now.
So they feel that they're getting exposed to, or they'll be liable for lawsuits if the patient is wealthy enough and they have the resources to pursue the legal system. So education of the physicians and the culture of malpractice has to change first on the supply side before you can penetrate or get this to kind of.
So that's one important concern that a physician might have. The other concern they have is that this will actually deliver extremely bad care. in complicated situations because of the complexity of it. That the hypothesis here is that we can protocolize anything, right? Any complex thing. I wish we had an ER doc here who could. Do we have an ER doc? We had an ER doc here who could tell us, what he or she thought of this. But I can tell you the ER docs that I spoke to in the last 36 hours and showed them this. I had every reaction ranging from vitriolic to vitriolic.
Isn't it dependent on the kind of ER service? I mean,
This is one kind, Arnab, this is like all ER stuff.
But we're talking about, a patient coming in for an appendicitis operation. I don't see why any doctor would say no.
Right, but ER is going to be, by definition, open to all emergencies, right?
Right.
So we are basically saying that we can put, that's a debate, okay? So there's a techno view, scalable, replicable once we get it going, possibly cost efficient, conserve on human resources because you maybe can manage with less highly skilled people. One of the nice things that's part of this experiment is that the local government public hospital is acting as a support center to the 10-bed ICU, which is in a remote place, which is a good thing, right? Because that's real doctors. And the skepticism is that this is too hard to do. And, just having doctors and algorithms try to deal with extremely complex cases is going to be very hard to do. Anyway, that's just the debate. The skepticism is that really what's going on is that these guys, and I have no reason to believe that this is true, but one of the skepticism is that there is a software set of packages that have been developed for dealing with the pandemic. And really the longer software game is you put these ICUs all over, and then the software company, which becomes a commercial company, can put its algorithms on top and make economic returns off it. That's another source of skepticism. I have no idea whether that's what's happening or not. This is an alternative. This is another outfit that started during the pandemic, right? It's called the Community Science Alliance, which is, as they put it, implementing contextually relevant protocols in basically poor countries. Right? And what is it? It's a set of checklists for what is a COVID-19 care facility. Like if you want to have a facility dedicated, so this was created during the height of the pandemic. And it ended up being in 30, 40 countries, including India, but not just India. The creators were one of my students at Harvard and an NGO in California. Not me, it has nothing to do with me. It's just these different people coming together. Checklists for administrators, basic education for how vaccine works, what drugs work, what drugs don't work, what are the benefits of it, in ways that the local community can understand. It's called the Community Science Alliance, right? So again, clinical pathways, centers of excellence, different hubs and so on. So this is what I would call, it's also tech enabled, but in a much lighter touch tech sense, right? So why is it tech enabled? Because all the sharing across the community science entities are being done, by technology. WhatsApp groups being the simplest of them. Expertise sharing is being done, real-time response. So for instance, you're going to go work for Facebook. So Facebook donated during the height of the pandemic, donated some data so that we could track mobility patterns during the pandemic. It was not the only one, but it's one of the entities that donated. So you could see as people's phones moved around, how people were moving during the pandemic. Right? So what we were doing was, as you could see more of this movement happening, you could then report it to the health authorities in a small city in some rural state in the United States, or some small place in Turkey, or some small place in India, and say that these are the data that we are seeing with the Facebook algorithms, and here's how you interpret the data. That's the important part. It's not the data. The data anybody can download and run a graph and say, oh, this is going down or up. But here's how you interpret it. Here are some policy considerations for you. That human link at the end is the distinction between 10-bed ICU and this thing. So why am I putting these two up? Because it's the kind of debate that we're having in the commission, to say that here's a completely techie approach, here's a tech-enabled human complement approach to it. And I'm not sure I have the answer for which is better. Okay, what else? One other thing I would say that there is no fundamental right to health in India. Right? Though, when you look at, I'm just thinking about the legal framework. So we've got a bunch of lawyers in the commission who are thinking about, is there a rights-based approach to healthcare that can be, so if you think about, step back and say, you're asking for massive system change, and you're asking for individuals to take more responsibility. What levers can be used to trigger this change process? To what extent can you use technology to make it easier? To what extent can you use the legal process to mandate some kinds of change or to hold people accountable for certain outcomes so that then the system calibrates and gets in that direction? As in this country, you can see, this country is, with Roe v. Wade being in the news, you can see that we have a patchwork of health-related kind of laws, rules, customs in this country, and India is the same mess or worse. So that health is kind of all over the map. So this is a tough one. Human resources, I would just say that if you look at number of health professionals per 10,000 people, the numbers are very low. Basically, we don't have enough, let alone trained medical doctors, of which we have very few. And there's rent-seeking here also, because the medical lobby is preventing there being too many more medical colleges opening up. Happens in every country, probably happens here also. The AMA interfering and making sure that its members are protected economically. Certainly happens in India, right? That the doctors say that we don't want too many of these. Why? Presumably because they'll compete with us. And the net result is that you don't have healthcare personnel. So in the short run, what do? You try to sort of find ways to do what we call task shifting, right? Which is to try to get simpler stuff to be done by less trained people, create protocols to make that happen. You see that in complicated procedures. But in the longer run, you've got to address the supply problem, is to do something about the human health. That's why we have this human resource kind of vertical in the commission to think about those kinds of things. I'm out of time. Last thing I would say is that the research area is being done by, as you can imagine, there's tens of thousands of papers written on these different aspects. So these 200 odd researchers are kind of collating all those research and summarizing them. That's a lit review phase. Lots of data collection in different ways. I don't have time to talk about it. And probably most importantly, the citizen survey that's being rolled out in pilot form and in different phases. I think the target survey size is 50,000 people or 70,000 people, just to get some smattering of input into this. And then we'll go from there. So we are out of time. So let me stop at that. And thank you for the back and forth.
Thank you very much, Tarun. Your talk was the closing of the emerging markets theme spring seminar. So very, very grateful that you made the effort to come. We are all trying to leave our caves and come back to normal life. Excellent talk, extremely relevant subject, not only for India, but for many other emerging markets. So other countries are watching. And I think it's extremely generous from your side to dedicate your efforts. You could be in Boston enjoying life, that you spend time in what must be is a fascinating project with tremendous impact, tremendous legacy, and at times probably a little bit uncomfortable because not easy to have all these people working at the same time, but very much needed to have a community. So thank you very much. Thank you, Arnab. I know that you had a problem with your shoulder and you came to present Tarun, so thank you. Thank you all. A special thanks to Andrew Foley, who did a great job organizing your all trying to squeeze everybody in less than 24 hours. I think he did a tremendous job. He worked very hard. So let's take a picture before you leave, a group picture, and I know that many people will want to talk to you, and I know that Ravi Kambur is waiting for you for lunch at Banfi. So and then you have to leave very quickly. So thank you very much.
Great, thank you.
So let's take a picture and thank you again and looking for more.
Take a picture.
So maybe we can all stand up behind the podium,
Or I can stand here and he can take, but there's no wide angle.
no, we're using a cell phone.
Mask, you know who is there.